So Dan Pratt is Senior Clinical Lecturer and Clinical Psychologist in the School of Health Sciences at Manchester University. He also leads the Patient Safety Research Unit at Greater Manchester Mental Health NHS Trust. His clinical and research interests focus upon psychological models of suicidal thinking and behaviour and the development of effective treatment to prevent self-harm and suicide. Dan.
Thanks, Jenny, and thank you for the opportunity to talk a bit more about some of my work and some of the interventions that we've been investigating in prisons. The focus of my work is on the use of cognitive behavioural strategies, or CBSP, cognitive behaviour suicide prevention, as a treatment option for people that are identified to be at risk of suicide. Next slide, please, Louise. Thank you. So by way of a bit of context, very briefly, we know that psychological interventions for suicide are effective for suicide and for reduction of self-harm as well. We know that CBT, or cognitive behaviour therapy, is particularly well evidenced, providing the focus of the CBT is suicidal self-harm thoughts or behaviours themselves. We know that CBT for depression or CBT for anxiety, let's say, is less effective at reducing self-harm and suicide. Suicide, self-harm has to be at the middle of the focus of the work of the CBT. And we know that NICE now recommends CBT as well for the treatment of self-harm. Next slide. What I want to talk briefly about today is a few of the trials that we've been involved in over the past decade or so. There's two studies mentioned on there in purple, the Prosper and the Prospect trials, that I'll mention in more detail in a moment, but I wanted to highlight the other trials that we've been involved in. That our intervention, our cognitive behavioural suicide prevention therapy intervention, was originally developed for people living at home in the community, but we've managed to translate and implement this therapy to people in other risky client groups, such as people with psychosis, people on mental health wards, and also people in prison as well. So let me talk a bit more about Prosper and Prospect. Next slide. OK, before I do, let me just briefly cover what we understand as CBSP therapy. So what it is: if you were a fly on the wall, what would you be seeing? You'd be seeing one therapist and one client. It'd be one-to-one therapy provision, talking therapy, although there is often some written materials provided to supplement the talk that goes on in the session. Typically, the therapy window is 6 months, maybe 4 months, 4 to 6 months. 20 to 25 sessions are offered, typically weekly, although the frequency of delivery can vary depending upon the needs of the client. Some clients are able to take 2 sessions a week. The target, the primary focus of these sessions is to better understand the role of key psychological factors, so namely hopelessness or negative thoughts the person might have about their future, entrapment, a sense of being trapped or stuck in a life that you don't enjoy or don't want, and a sense of defeat or powerlessness to make any change to this life. We know that hopelessness, entrapment and defeat are key drivers to thoughts about suicide and self-harm. So they're the factors that we try and target. Before we try and make any changes with the individual, we develop a formulation with that person to understand how this person thinks about suicide. And then with that formulation, we then target certain aspects of their experience with established CBT techniques to try and to build with that person a more helpful way of responding to their suicidal thoughts or their self-harming thoughts, and try and strengthen their resilience, their sense of being able to live with a difficult set of circumstances without the need for self-harm or suicide, let's say. OK, next slide, please. The next few slides I'm going to present provide a summary of the work that we've been doing in prison, namely in the Prosper trial and the Prospect trial. Next slide. Thank you. So for Prosper, which was our first trial, this was a pilot trial, so a bit similar to what Kerry and Louise were talking about around before you're let loose with a large-scale trial, you have to have a kind of proof of concept, proof that you can deliver the trial in the new setting, in prison in this case. And so our Prosper trial was focused on 3 key questions. One around pragmatics. Can we offer this therapy to prisoners? If we can, how? then the context, what gets in the way of or what helps us deliver this therapy to suicidal prisoners or prisoners that are at risk to themselves. And then more importantly, or not more importantly, just as importantly, what's the organisational support for this approach, this intervention? Does the prison want it? Does the NHS want it? So those are the three primary questions. Next slide, please. So Prosper was a 3-year study that we did a few years ago now, and it was a feasibility trial. So a small-scale pilot trial, 62 prisoners on an ACT. That's how we identified people to be at risk of suicide or self-harm. All the 62 prisoners completed a battery of questionnaires that measured various outcomes at baseline, so before any therapy was delivered, and then at 4 months and 6 months later. Next slide. Of the 62 people in the study, 31 were randomly allocated to receive our CBSP therapy. 4 individuals, 4 of those 31, chose not to complete the therapy. They'd had a look, they'd had a go, and they decided it wasn't for them. And that's worth bearing in mind, that I'm not in any way suggesting that this intervention is the panacea. It's not the one size fits all. It's not appropriate for some people. Let me jump ahead a couple of bullet points. 18 people completed the therapy, so they attended a sufficient number of sessions. But 9 people, 9 out of our 31, were lost during this trial. They were transferred out of the prison. I should have mentioned this pilot trial took place in HMP Manchester, and we lost 9 participants, which is perhaps to be expected in a prison-based trial, but it's a real nuisance variable from a kind of trial perspective. But that's one of the lessons that we've learned from conducting trials in prison. We have to expect a higher number of dropouts. For those people that received the intervention, the average number of sessions attended was 14. That's really impressive, I must admit. In the community, when people can come and go as they please much more easily, our average number of sessions was 12. And so people in prison want these sessions and arguably value the input that they're receiving in these sessions. Our number of cancelled sessions and our number of sessions that weren't attended were low, and they were no different from what you'd expect to see in the community. So that says an awful lot about the acceptability of this intervention. Next slide, please. What we also took a sneaky peek at that we probably shouldn't have done really, and so I don't want people to pay too much attention to this slide really, but we also had the opportunity to look at what impact, if any, did the therapy have on a person's risk of suicide. And so the study is far too small to make any reliable conclusions from this. But what we can see from this graph here is that the blue line shows that the group of individuals that were allocated to the control arm of the trial, they didn't receive the therapy, they improved. The blue line is going down from left to right. But what we can see for the red line, which indicates the therapy group, is that the recovery experienced by the therapy group was more. They had a differential level of recovery. Now, I don't want to make any big claims about this, but it appears that receiving access to this intervention is associated with a stronger decrease in suicide risk. Next slide, please. If you want to know a bit more about the results of the trial, it's on this paper. I can easily make it available to you. It's freely available now as well, but there's a reference there as well. Let's move on. Sorry, next slide, please, Louise. If we move on to the prospect study, then one of the aims in terms of developing evidence base, so we've got this evidence from the pilot trial to suggest that we could do a trial, albeit on a small scale. The next question we have to ask is, can we repeat it on a much larger scale so we can be more confident in our results? That's what we've started doing now in the prospect study. So this is another NIHR, NHS funded study, and the aims of the prospect study are to again provide access to this CBSP therapy to prisoners identified on an ACT, and this time we're able to look in a proper way at the clinical and cost effectiveness of the intervention. Next slide. Prospect comprises of 4 different packages of work. The first of which emerged out of the work we did in Prosper, the pilot trial. What we became aware of is that a number of individuals accessing the therapy in Prosper needed a bit of help to find their feet in the therapy, needed a bit of help to find their voice. And so what we're trying to do in work package 1 is co-produce with multiple stakeholders, academics, clinicians, but most importantly, people with lived experience of feeling suicidal in prison, co-produce a new resource, a self-help resource that can support people in better preparing them, better skilling them up for a course of CBSP therapy. In work package 2, we're going to look again at how best to adapt the delivery of CBSP therapy within a prison setting. And we're also going to develop a theory of change or a model of how this therapy should reduce the occurrence of self-harm and suicide in prisoners. Work package 3 is the largest of the 3 work packages. This is our trial. This is the full-scale randomized controlled trial of the delivery of CBSP. 2, we're hoping to recruit 360 prisoners across 4 different prison sites in the Northwest and in the Yorkshire regions. And then alongside the delivery of the trial, we're also going to do a process evaluation that again allows us to unpick what are the barriers and facilitators to implementing access to CBSP in routine practice. I'm very much of the belief that we don't want to run this trial that shows it has an effect and then the trial results just sit on a shelf. Out of Prospect needs to come an implementation manual of how any governor in the land or any head of healthcare can then implement CBSP therapy in their prison should they wish to, if the evidence would support it. Next slide, please. I want to conclude my talk with a few slides that's a bit more real world rather than researchy talk, and that's around the implementation challenges that we've experienced. That will be, I would imagine, relatively commonplace to anybody that works in a prison, but I think it's worth articulating some of these here, and I've categorized them as challenges that we might position at the feet of the individual, the prisoners themselves, and then broader challenges that might come about because of the context we're trying to offer help within. Next slide, please. So in terms of individual challenges, I'm sure we all recognise the fact that imprisonment affects individuals in a variety of different ways. That's really important to bear in mind from a therapist perspective. The way we would approach and what we would offer a person who's first time into a prison has to be differentiated from people that have been in prison an awful long time and they know their whereabouts, they know how they fit within the regime of the prison. We also have to meet the prisoner where they're at, and where they're at may vary depending on how safe they feel in the prison. And so hypervigilance, distrust of colleagues, of staff, of peers, that may well be quite commonplace and that may be particularly helpful. I'm sure we've all come across prisoners that present themselves in a particular way in order to mask or hide their vulnerabilities. It makes a lot of sense to me. But that kind of prison mask that people may present with often gets in the way of being able to offer good quality therapy where we want to get into the nitty-gritty of what's making a person think about self-harming or thinking about ending their life. And so we have to try and find ways of getting through that prison mask or providing a sense of safety and containment for that individual who's about to start therapy. Next slide, please. We also have to think about the likely lack of familiarity with therapy, and wrapped up in that is also the way we present the therapy to people. We learned very quickly not to call it therapy because that for some people, came with certain connotations that we were keen to avoid. And so we tend to refer to the Prosper programme or the Prospect programme because this terminology seems to be more familiar and more accepting to people in prison. We have to recognise that the emotional literacy is often skill is often low amongst some of our prisoners, and so we again have to meet them where they're at. And some of our preparatory work might be around skilling them up into being able to talk more about how they're feeling. And we also have to talk about homework tasks or between session tasks. I've never in my life suggested to a prisoner that they do some homework. I think I'd just get laughed at, but it's important to recognise the importance of trying to implement any skills discussed in therapy sessions outside of the therapy session. And we have to think and be creative about how we go about doing that within the limitations of the prison. Okay, next slide.
Dan,
Yep.
Dan, can I just ask you to be quite brief with the rest of your presentation, because we're rapidly in the question and answer. So,
happy to be, Jenny. Yep, just bear with me. I've only got a couple of slides to go.
Thank you, Dan. Thank you.
Not at all, not a problem. And then just a couple of slides on contextual implications. As I've mentioned already, the impact of the security and the management of security in a prison has to be borne in mind in delivering interventions, lockdowns, unplanned releases, ongoing court appearances, etc. That's important to bear in mind. Not that much we can do about that, I suppose, and so therefore we have to think about remaining aware of potential premature terminations of therapy. The practitioners have to remain aware of any potential discharge dates or transfer dates if they're aware of them. Okay, next slide. More broadly speaking, I'm suggesting that the therapist will be best placed to ingratiate themselves with the way that the prison works, how the prison handles and manages self-harm, how the prison culture understands self-harm. That's really important for the therapist to bear in mind. The model that we've often followed and we continue to follow is that the therapist is an NHS employee. So they're kind of an outsider, but working on the inside, if you don't mind. And so there is a slightly independent perspective that our therapists take, but there is also obviously close collaboration and close links of working with the prison teams as well. Okay, that's a brief end to my presentation, but I hope I've managed to put across the essence of what I've talked about, and I'm very happy to take any questions on this. Thank you. Thank you, Jen.